Asif, are you here?
Sir,
I'm here, sir. Should I start?
Live now. You can start. Yes, sir.
Okay.
We're live now.
Assalamu alaikum and good evening, dear respected physicians. Welcome you all in today's lecture session presentation organized by ECG Study Group. Today is our 44th lecture, and today's topic is AV conduction disturbances and abnormalities. And the presenter today is a special one, Dr. Abhishek from Mayo Clinic. Before starting the procedure or the lecture, I'd like to request Professor Abdul Wadir Chaudhary sir to speak about Dr. Abhishek Deshmukh, and we proceed then on. Wadir sir.
Good evening, everybody, and assalamu alaikum. Before starting the program, I have to say to the audience that our Dr. Tushar is actually suffering from COVID. Still, he is here to start the program. That's very graceful of him. And I'm praying to God Almighty that he should get well very soon. Now, today's lecture will be given by Dr. Abhishek Deshmukh. He's a cardiac electrophysiologist and an outcome researcher. He's a co-program director for Electrophysiology Fellowship Program at the Mayo Clinic. Dr. Deshmukh performs invasive procedure such as catheter ablation and device implantation to treat heart rhythm disorders. He is specifically interested in ablations and device management of patients with infiltrative cardiomyopathies and adult congenital heart diseases. He has an active research program where he uses large database to examine quality, outcomes, and the risk prediction for heart rhythm disorders. He has been voted as the Teacher of the Year many times. Today, we are going to observe why he has been voted like that. We have enjoyed his lecture before, and I'm at least myself eagerly awaiting to hear from him in today's lecture. Dr. Abhishek Deshmukh, the field is yours.
Thank you very much, and good evening, everybody, and hope Dr. Tushar, you feel better soon. You know, I hope we get over this COVID pandemic sooner and everybody remains healthy. So I'll share my slide and let me know if this is, you can see it and you can hear me. Okay, yeah, perfect. So our main learning objectives today, when we talk about AV conduction abnormalities, is really to have a systematic approach to slow heart rates on ECGs. And when do we think this is AV conduction or SA node conduction disease, and how to really tease through each of these things, we'll talk about that. And then finally, if we can use this ECG as a clinical pathological a tool for more correlation of what might be going on clinically with that patient. So when we think of AV conduction abnormalities on the ECG, the first step really is to find out if it is really a true AV conduction abnormality. If it is true, is it physiological or pathological? Is it dangerous for the patient? And then are we getting AV conduction abnormalities because is it a failure of impulse generation? Or we are getting AV block due to failure of impulse propagation? And then finally, if based on the ECG, if we can predict what could be the underlying pathology, and then what are the clues on the ECG that can help me acutely and actively with that particular patient. So this is in the broad term how I would approach an ECG when I'm thinking there is some AV conduction abnormality going on. So when we think of AV conduction abnormality, our main aim is to find out if there is a problem in the PR interval. Now we all know that QRS is a vector or a summation of vector from LV and RV activation. And the PR interval is actually the onset of time from atrial depolarization to the ventricular depolarization. So whenever we think of a PR interval, we always think of AV node, but it is a little bit beyond the AV node. It is really the time it takes from the sinus impulse firing through the atrium, and then when it reaches the AV node, that's basically our PR interval. So once we understand that the PR interval is not only what happens in the AV node, but also what happens in the atrium, I think then it can tune us more to identify the block, maybe even identify the underlying pathology the patient might be happening. We all know that the AV node is a very, very septal structure. So when the activation is going towards the AV node, then from there it goes to the bundle branch blocks and then activates the left and the right ventricles. So let's start off with this ECG. Why is the rhythm slow? And maybe we can do an audience poll. Sinus bradycardia, AV block, beta blocker overdose, or pseudo sinus bradycardia?
Can you start the poll, please?
Ripu, can we start the poll?
Yes, sir. Starting the poll.
So why is this rhythm so slow in this patient? Heart rate 39 beats per minute. Is there AV block, beta blocker overdose, sinus bradycardia, or what might be really going on with this patient? All right, can we see the can we see the result?
Rivu, cut the poll time to
Yeah, make it 15 seconds. Yeah.
So we can see in the screen, answer A is 22%, answer B is 28%, and beta blocker overdose is 22% again, and lastly, pseudosinus bradycardia is showing 28%. Over to
Wonderful. Wonderful. So wonderful. So this is what exactly I wanted to know. There is a wide spread in the responses. And here I think we could make a point that why is this rhythm slow? So whenever this is actually pseudosinus bradycardia. So I'll talk to you a little bit more about this. So whenever the patient has a slow heart rate, the first step is really identify, is it a sinus bradycardia or is there a problem in the AV conduction? So here you can see the PR interval is pretty good in the beats which conducts. So maybe this may be something funny here going on that might be cluing us in whether this is 2-to-1 AV block or is it something else going on. When we approach this ECG, it is critical to know how the P wave looks like in a particular patient. So if this is the P wave, P wave, P wave, P wave, P wave, and suddenly on the T wave or suddenly close to the T wave, you get a very funny looking beat. So you have a P wave here, P wave here, the T wave has happened, but there is a very funny beat here which looks quite sharp, quite pointed compared to the sinus P beat. So if this P wave if this is a genuinely sinus, if it's genuinely a atrial depolarization or P wave, it really cannot be the sinus P because the sinus P looks like this, positive and then negative, and this is all positive. So when that happens, think that you're having a PAC, premature atrial complex. And it is not uncommon that a lot of patients have these PACs. They kind of land on top of the T wave. And when you have a PAC, it can actually suppress the sinus node. That's why you can have this pause and then you have sinus rhythm starting again. Now, this can also happen in a pattern of bigeminy. So we know PVCs can happen in bigeminy, but even PACs can happen in bigeminy. And what if these PACs, as they're happening in bigeminy, are getting blocked? So that may give you a false appearance that you're having a 2-to-1 AV block, but actually this is just blocked PAC and nothing needs to be done for this, and certainly no indication for a pacemaker. So again, going back to our ECG, so sinus rhythm, QRS, T wave, and a very positive P wave, which is very sharp, very pointed, and that tells us this is a PAC. It is just that this PAC gets blocked, suppresses the sinus node, so the next P wave happens, QRS happens, and this is happening in a pattern. And then towards the end, these PACs go away and you get resumption of sinus rhythm again. So this is an example of pseudo-sinus bradycardia. Now, when we look at
Dr.
a sinus,
Abhishek.
yes, sir.
Yeah. if the patient complains with dizziness in this
Mhm.
pattern with this ECG, can we straightway go for PACs, bidimensional form,
Yes.
or
So
should we have to
whenever
think something else? Because
so
if
if
the
the
patient complains about dizziness or vertigo, or
yes, so the patient can complain if the patient is symptomatic and they are having blocked PAC. What I try to do is increase the heart rate. So the way you could do that, you can just take the patient for a walk and see if the PACs go away. If the PACs go away and the patient is still dizzy and lightheaded, you know that the PAC is not causing any of those symptoms. So it is just like a quick stress test you can do at bedside, have them do some exercise, increase the sinus rate so that these PACs, get suppressed. And then, if the symptoms resolve, then it might be PACs. Symptoms don't resolve, then you have to call ENT, neurology, other people involved to figure out why they're having vertigo and dizziness. Is that okay?
okay, okay, sir.
Okay. Now, next, it is
I have a
important.
quick question.
Yes, yes, sir.
Why do you pseudo?
Because it is not true bradycardia. That's why I call it pseudo bradycardia. So next we'll look at the P wave morphology. Now we all know that lead V1 P wave is positive and terminal part is negative, and 1 AVL the P wave is positive. Now this is helpful because when we are looking at these PACs, important to know that how the sinus P looks like and whether those PACs are looking different compared to what we are seeing on the block PAC. So they can be quite dramatic that you may even think there is a 2-to-1 AV block here, but actually there is again a PAC. Again, a clue would be to look at the T wave. If the T wave is looking different where there is a block, think that there is a PAC which has happened and really nothing needs to be done for this particular patient. So when we think of bradycardia, we are obviously thinking of sinus node dysfunction and AV block. So we'll change gear to this patient. So 84-year-old gentleman with syncope. What might be going on here? I don't have an audience poll, but is this AV block or is it sinus node dysfunction? So we can just have A and B. Sinus node dysfunction is number 1, AV block is number 2.
So
Sinus
I
node.
will stop. Yeah, I will stop sharp at 30 seconds. So it's on.
Okay.
So I will check.
Sinus node dysfunction number 1, AV block number 2. So as people are thinking, you have PR interval, T wave looks the same. So there is no block PAC, T wave, and boom, there is no P wave anywhere, QRS. And then maybe there might be something here and a T wave.
Very good
So this,
result in your screen.
okay, great. So I think a lot of people identified it correctly. This is potentially an episode of sinus block or block in the sinus node or sinoatrial exit block, and we'll talk about that. And then you have this junctional beat with sinus node restarting again. So when we think of sinus node exit block, again, I'm showing this in the topic for AV block because sometimes it becomes confusing. So in our own mind, when we think of patterns that, you have group beating, then we think of Wenckebach, you have fixed, 2-to-1 type block, then we think of AV block. But before we see that, we got to understand what is being blocked. So in this first panel, you can see P wave QRS, P wave QRS, P wave QRS, no P wave, and then P wave and QRS. So there was no P wave, and that no P wave resulted in no QRS. So failure of impulse generation, that the impulse did not get generated in the sinus node. Same thing happens here. There is no P wave. Well, you may say, is this block PAC? But no, because the T wave is exactly the same. So this cannot be a block PAC. So it is just failure of impulse generation from the sinus node. Compared to here, so this is an example of sinoatrial exit block Mobitz 1, where you can have group beating, no block PAC, and there is no P wave in this pause. Compared to sinoatrial exit block Mobitz type 2, where you have sinus rhythm going on, and suddenly there is a block without the P wave. The fact that there is no P wave, we know that this has to be a block in the SA node, because if there was a P wave followed by no QRS, then the block would be at the level of AV node. So the fact that there is no P wave here, it tells you that the block happened at the level of the sinus node. And then for Mobitz 2 sinoatrial exit block, the P to P interval is constant, and the pause is basically twice the P to P interval. So if you look here, this P to P interval is constant, and the pause here is twice of the P to P interval. So that is SA node exit block Mobitz type 2. So the fact that you can have Wenckebach or Mobitz 2 in AV node, you can also have it in the SA node, and the treatment can be different, because these patients would need a pacemaker if you have this kind of sinus node dysfunction. Another story here. Patient is getting monitored for some medical condition, and the nurse calls you at 11:30 at night that the patient is having this. So what should we do? Number one, go back to sleep. Number two, pacemaker.
So I'm launching the poll.
Okay.
Yeah.
So 11:30 at night, nurse calls you that the patient, or your resident calls you that the patient is having a long pause. So what is your next step? Number one, you tell the patient, or you tell the nurse or the resident to go back to sleep. Or number two, you come and do the pacemaker. All right. So what is the answer?
Yeah, sir, I'm giving people are polling, so I'm giving another 2-3 seconds extra to them. So
Okay.
we are almost done. So yeah, I end the poll, and now I share the result.
Good. Some of them said that the person who called you can go back to sleep. Other people would sit in their car or on their bike and come and do the pacemaker. Good. So good spread. So let's look at
I'm
this.
glad that you did not give a third option, that call your intervention is for a temporary wear.
Yes. I'm glad I didn't give that option, because that should never be an option, right? For this ECG.
Exactly.
Good. So let's
Because
look at this.
I'm an interventionalist.
Yes, sir. So let's see this ECG or this telemetry. You have PQRS, 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 and then the P to P gets longer and the QRS to QRS gets longer. And then there is no heartbeat for a few seconds here. And then, heartbeat starts again. And again, you have a long pause and heartbeat starts again. So the fact that this is not happening suddenly, there is prolongation of the P to P interval, prolongation of the R to R interval during sleeping hours, means this is just high vagal tone during sleep. And really nothing needs to be done for this. No indication for pacemaker. And, we should just tell our patients to get checked for sleep apnea, or lose weight and all that, but really no indication for pacemaker for this particular situation. No indication even for a temporary pacemaker for this kind of patient. So, these blocks will recover, and I would just wait and watch and see how things go. So this is again pause during sleep and nothing needs to be done. So when we think of AV blocks, we think a block at the level of AV node. So first degree AV block would be just prolongation of PR interval. Mobitz type 1 or Wenckebach, will show you some example. Mobitz 2, 2-to-1 AV block, advanced heart block, and then complete heart block. So this is an example of first degree AV block where just the PR interval is slightly prolonged, but there is no AV block noted anywhere. This is an example of Mobitz type 1 AV block. So PR gets longer, blocks, and then you have return PR is quite short. Again, critical to know when it blocks, whether it blocks in the P wave or blocks in the AV node. Now again, if you look closely at these T waves, and actually T waves are your friend when you look at these things, is look at this T wave compared to this T wave. The fact that this is more pointed and notchy compared to this tells you there is a P wave which is hiding here, and that's what you got a P wave and then it blocked. and then the return P wave PR interval was shorter. So this is Mobitz type 1 AV block. This is Mobitz type 2 second degree AV block, where you have P QRS, P QRS, P no QRS, and again P QRS, P QRS. So this is kind of a block, Mobitz type 2 AV block. Now, interesting thing, sometimes you will see here that this P to P interval is longer compared to the P to P interval where there is actually conduction happening. And that if you read like classic ECG textbook, they call it as ventriculophasic respiration. So this is an example of Mobitz type 2 second degree heart block. So when we think of Wenckebach or Mobitz type 1 AV block, what is exactly the same is actually the P to P interval. So the P to P interval doesn't change. The PR interval gets longer and blocks, and the returning PR is the shortest. And again, the PR interval gets longer and blocks. But even more important is that when you look at the block, the duration of the block should be less than twice the preceding RR interval. Because sometimes it's really confusing if you don't see the P wave or the T wave is not, or looks very, very similar. Main thing would be to just look at the block interval. And if that block interval is less than 2 times the preceding RR interval, then this is Wenckebach. In second degree type 2 AV block, the P to P interval again remains the same. PR interval remains the same, but the block is exactly twice the preceding twice R to R interval. So if the block is mathematically exactly the same as twice the prior R to R interval, that is consistent with second degree type 2 AV block. So important concept to know, because generally for second degree type 1 AV block, you don't need a pacemaker. Second degree type 2 AV block, we have to start thinking of a pacemaker if the patient is symptomatic. Another thing to remember, however, for patients with Wenckebach or even Mobitz 1 or even first degree AV block, if the PR interval is longer, say more than 250 milliseconds, and the patient have say myotonic dystrophy or some neuromuscular disorder, then they actually need a pacemaker. So the only time you would give a pacemaker when the PR interval is longer is without an AV block, is somebody with the myotonic dystrophy. So it's a point to remember. This is an example of 2-to-1 AV block. Again, P, QRS, P, QR, no QRS, P and QRS again. And again, the fact that this alternate P doesn't conduct to the QRS, that tells you that this block is at the level of AV node and 2-to-1 AV block. This is high degree AV block where you have many P waves, but they don't create enough QRSs. So this is high degree or advanced AV block. And then this is complete heart block where there is complete AV dissociation, meaning you have P wave, P wave, P wave, P wave. P wave is going at its own rate, QRS is going at its own rate, and the P waves are really not talking to the QRS. So kind of dissociated rhythm. So this is complete heart block. Now, it's important to know these various patterns because, not everybody with these things need a pacemaker. So even if you have a transient complete heart block during sleeping hours and patient is snoring away to glory, you really don't need a pacemaker for those kind of patients. But sometimes it becomes tricky that, somebody has 2-to-1 AV block, we see it on a Holter or some monitor, or the patient is even sleeping, when to be really concerned about. So again, if you remember, the electricity in the heart goes from the SA node, AV node, His bundle, and then the bundle branch blocks. If there is a block at the AV node, then at least the His may fire and you may have a resumption of conduction. But if the block is at the level of His, then you are extremely concerned, and those are the patients who would need a pacemaker sooner than later. So how to sort this out clinically? So generally, when there is a block at the AV node, the PR interval is longer, the QRS is much more narrower, and the escape is very similar to the escape what you see with the QRS. I would not suggest this to do it, but the block will actually worsen with vagal maneuvers. But the trick what you can do is to take the patient for a walk. If you take the patient for a walk and is in 2-to-1 AV block, and as the heart rate increases, the block gets better. That means the block is at the level of AV node. and that patient doesn't need an urgent pacemaker. On the other hand, if the QRS is wider, the QRS with conducted beat is different and narrower compared to the escape QRS. And actually, if you take the patient for a walk and the block worsens with exercise, then think that the level of block is at the level of his bundle, and then those are the patients who need a pacemaker. So common things, sometimes somebody comes for a treadmill stress test. They go for exercise. During peak exercise, they have AV block or 2-to-1 AV block. That's a bad marker. That's a marker that this patient needs a pacemaker, may even be ischemic to have exercise-induced AV block. So important to know that we identify these patients and get them a pacemaker. We'll talk about few clinical scenarios. So 75-year-old female with bradycardia. Which doctor would you call? Number 1, cardiologist. Number 2, endocrinologist. Number 3, nephrologist.
What is the potassium level?
Oh, Dr. Vadud already astutely answered. So good. So even before you call a doctor, you just check a potassium level. And any guess, what do you think would be the potassium level here, sir? Based on this ECG?
At least around 7 or more.
Oh, at least 7 or more. Less. Actually, the potassium was exactly 7.2 here. So the Dr. Vadud astutely pointed out that this is hyperkalemia. Hyperkalemia can also cause bradycardia, maybe sometimes AV block, and then we need to check the potassium. Potassium was actually 7.2 after dialysis. So nephrologist came in, the potassium got better, 4.8, and the AV conduction improved. So again, important to know that not all AV blocks and bradycardia, you have to call a cardiologist, and sometimes our nephrology friends can also help us to treat this hyperkalemia. This can help in correcting this cause. So just some pointers about hyperkalemia. Just tall T wave, your potassium is 5.5 to 6.5. But when you have tall T waves with loss of P waves, as we saw, then the potassium is between 6.5 and 7.5. So in our patient, the potassium was 7.2. And when the potassium is higher, then you have more QRS widening, asystole, arrhythmias, and everything else. But say between potassium 6.5 and 7.5, T wave is taller, you lose the P wave, sine P wave pattern, then start to think that this is hyperkalemia. All right. Now we talked briefly about arrhythmias and sleep. So this is another tracing where during sleeping hours you have PR prolongation blocks. But again, this happened at 12:56 a.m. and really nothing to do. But sometimes these things become dangerous. So if they start to have some non-sustained VT during sleep, during bradycardia, that's a bad marker. So those are the patients I would actually offer them a pacemaker. Because what happens if you have bradycardia, you get these short, long, short sequences. And so suddenly the heart rate is changing. Sometimes it is fast with the bradycardia or pause, the heart rate becomes very long. Then it becomes short again, and you can have this non-sustained VT. So if you have these arrhythmias with pauses or blocks, and in the middle of that, you're having some non-sustained VT, that's not a good sign. Those are the patients I would consider actively for a pacemaker. So not everybody with bradycardia at night needs a pacemaker, but if the bradycardia is causing some short runs of VT, then think of pacemaker for those patients.
But we'll not consider ICD, is it?
No, not ICD, because you treat the slow heart rate and the patient will get better. So generally nocturnal bradycardia itself is not an indication for pacemaker, but you should screen for sleep apnea and all those things, and that will help a lot in finding out why they are bradycardic. But VT during sleep it's not good, and those are the patients who need to get paced. I saw a question on the chat about ACS and complete heart block. So this is an ECG. So someone coming in with chest pain, whom should they see? Interventional cardiologist, number 2, electrophysiologist.
So I have launched the poll, so we'll wait for some time.
Okay. Only give 10 seconds. It should not take more than 10 seconds.
Yeah, I have another 3 more seconds. Done.
Okay. Interventional cardiologist or electrophysiologist? Fantastic. Interventional cardiologist. Good. So acute MI can also cause heart block. So this is a classic example of inferior wall MI. So you can see ST elevation 2, 3 AVF, 3 more than AVF, and then 2 is the least. And then you have this sinus tachycardia actually going on with the complete heart block. So these are the patients who need revascularization first. And generally, as a rule, patients with inferior wall MI with complete heart block will recover, generally as a rule. So, this is the angiogram of that patient. You can clearly see the artery was blocked and then treated. Another patient here, chest pain, heart block, and again, some ST changes, 3 more than AVF more than 2. So again, kind of a proximal RCA infarct. But here what happened in that particular patient, there was a lesion in the proximal RCA, but you can see there is no blood going in the posterolateral branch. So this is a posterolateral branch which actually supplies the AV node, and there was no blood supply going there. So once this the proximal RCA was stented and the flow in the PL branch was restored, you can see a large PL branch going all the way up to the AV node. The patient's AV conduction got better. So generally, when we think of AV block in inferior wall MI, think of basal-Jarrett's reflex, increased vagal tone secondary to ischemia. There can also be ischemia to the SA node or AV node. A lot of these patients get morphine, so it can cause some bradycardia. And reperfusion bradycardia is also known in these patients. So a lot of times patients with inferior wall MI would get bradycardia and heart block, but they generally don't require pacemaker. At least by guidelines, you can wait for several weeks before considering a pacemaker. Different story. What's going on here? And which doctor would you call? Intensivist, cardiologist, or electrophysiologist?
The time starts now.
So patient comes in with worsening shortness of breath, and somebody in the casualty or emergency room notices the AV block, and they think, this patient, because of slow heart rate and patient had near syncopal event, so they want to give a pacemaker. But you walk in as an internal medicine doctor and you think, well, this is not as clean as it may sound, but there is something else going on. So what's going on here?
So a little bit of mixed bag result as of now. We'll wait another 10 seconds.
I'm on a call. 10 minutes. All right.
So I end the poll and I share the result. Just a second. Yeah.
Good. So good spread again. So again, this is Wenckebach, Mobitz type 1 AV block. But again, we talked about Mobitz type 1 AV block doesn't need a pacemaker. But what's actually going on with this patient? Can somebody just shout out and tell me what's going on? PVC. Okay, what else?
So
I don't understand Bengali. So what did you say? Dr. Wadud, what would you think? What's going on with this patient, if I can ask you?
Actually, sorry, I missed I was talking on the ICU.
No, but just what is so your ICU doctor just called you. Somebody is with Mobitz AV block and they send you this ECG. So what would you think is going on with this patient?
The patient has Wenckebach phenomena, but the point is why he is having these PVCs.
Yes, but beyond that, what else is going on? So when we think of these situations, we look at Wenckebach, we look at PVCs, but if you look at the big picture, this is classic S1 Q3 T3 pattern, which is seen in acute pulmonary embolism.
Yeah.
So when you have a massive pulmonary embolism, patients can have syncope. They can also have a very high vagal tone like basal-Jarrett's reflex, and they can have Mobitz type 1 AV block. So when we're looking at any ECG, whatever our specialty is, we have to look at the big picture. And just based on this S1, Q3, T3, a CT was performed, massive pulmonary embolism was noted and then treated. But then the question was, why did the patient did not become tachycardic? Because sinus tachycardia is the most common finding for pulmonary embolism. But if you have a really massive pulmonary embolism, you can have high vagal tone, basal gyrix reflex, and that can cause bradycardia and Mobitz type 1 AV block. So something to think about. And it's also not uncommon that you can see this acute pulmonary embolism type pattern when you have these episodes. So this is an example of complete heart block in somebody who is 45 years of age. So generally, when you think of young patients with complete heart block or high AV block, think of degenerative conditions, infectious causes, rheumatic, autoimmune diseases, infiltrative diseases, neuromuscular disorders, radiation induced. A lot of these things can cause heart block. Now, I think I'll skip this and I wanted to show one more example here. What is going on here? So you have a P wave, QRS, P wave and no QRS. Sometimes what can happen, the P wave can go to QRS, but that same P, you may not have a P wave, but that second P, the first P wave can also make another QRS. That is called as double firing. So one SA node is creating activation going down the fast pathway and the slow pathway. Or this can also be junctional escape or junctional beat. So, this is not AV block. There is no block here. It is just that same P wave is creating a QRS and another QRS. So kind of double fire, or can also be seen in junctional rhythm. So junctional rhythm can be of different shapes and sizes. So sometimes we look at these retrograde P waves, but when you're having a junctional rhythm, the junction is firing, and then it's really the race who wins. Does the QRS wins or the P wave wins? If the atrium or the P wave wins, the P wave is going to be before the QRS. If the ventricle wins, meaning the QRS wins, the P wave is going to be after the QRS. So you can get junctional rhythm of various forms and shapes. So P wave before QRS may not have any P wave if there's block to the atrium, or even P wave after the QRS. Lastly, certain congenital heart disease are at a risk for AV block, common being congenitally corrected transposition of great arteries. So normally blood goes from right atrium, right ventricle, pulmonary artery. But in these patients, the blood goes from right atrium, left ventricle, and then the pulmonary artery. So the ventricles are flipped. So whenever the atrium and ventricle and the ventricle and the artery is flipped, it is called as AV discordance, and that is CCTGA. Why this is important? Because we know the septal activation happens from left to right. So that's why you have Q wave in 1 and AVL. In these conditions, because the septal activation is happening from right to left, they don't get a Q wave in 1 and AVL. So that's your clue. Young patient, complete heart block. Why would there not be the septal activation be abnormal? So think this is a congenitally corrected transposition. They're at a high risk for AV block. So this is why an ECG of that patient and got a device and then got better. And lastly, I wanted to show you this one last ECG on paced rhythm. So you can see atrial pacing and a very long PR interval. So like we said in the beginning, that PR interval is the onset of atrial depolarization to the ventricular depolarization. But sometimes you can have atrial pacing and you can still have a P wave after that. That means the conduction in the atrium is so slow that if you pace somewhere, it goes, makes a P wave, and then goes and makes a QRS. So this is actually not this long of a PR interval, but this long of a PR interval. And that also tells you that it's not always that AV prolonged PR interval is because of conduction disease in the AV node, but can also be significantly seen when there is a lot of scar going on in the atrium. So in summary, when we look at these ECGs with AV block or slow heart rate, develop a plan, see what is blocked, what is conducted. So if there is a block, see if there is a block PAC or truly a block in the sinus node dysfunction, or a block in the AV node. Look for the P waves, look for the T waves, see if the T waves are more pointed compared to the P waves. and then try to correlate this physiology with the ECG pattern and not the ECG pattern with the physiology. Because if you correlate physiology with ECG pattern, so sleep, bradycardia, high vagal tone, no need for a pacemaker. But think of it that way rather than thinking, oh, just because somebody has AV block, regardless of the time of the day, they need a pacemaker. So we might be doing a lot of unnecessary things to our patients. So just look at physiology and then look at ECG patterns. And I think that will help you a long way in taking care of your patients. So I think I'll stop here and thank you very much for the kind invitation. Sorry, I went overboard. I have few other things and maybe we can
really
discuss it at some
enjoyed
other time.
And Dr. Deshmukh, if you wish, you can go on a little bit more. We are really enjoying it. And for your information, many of our audience is also from Nepal.
Yes.
Our Nepalese colleagues and friends are also joined there as faculties. And the
Yes.
audience is also their residents and cardiologists, young cardiologists there. They also join us.
Good. So I think I'll stop here, but if you have any questions, I'm happy to take some. I'll just stop share.
Dr. Arun, do you have a question? Professor Arun Maski is professor of cardiology in Nepal.
Yeah, I'm enjoying its lectures. Very nice and basic lectures. Refreshing ECGs. That's very fantastic, Vardhan.
Thank you, sir.
Nice lecture. And we have a lot of MD residents here join.
Good.
So they enjoy this ECG lectures. Thank you for your excellent and wonderful lecture.
Thank you. I hope they all pick up few things. Just look at P wave, look at QRS, try to see where the block is. And once you get this basic understanding, you are going to write an ECG book yourself. So no need of reading ECG book to know, to look at these patterns. Once you understand this basic concept, that itself is good enough for you to identify any possible ECGs. So I wish you all the very best.
Thank you, Dr. Deshmukh.
Thank you.
Dr. Jamil, do you want to comment?
Thank you very much, Dr. Deshmukh, for a nice deliberation. I was just having recapitulation of my knowledge. Many of things was not theoretically, I was forgotten many things and I have just recapitulated those things. And these are the basic things which all the fellows should know, as because in examination these things are frequently set in the theory exam as well as in the Bibles. Thank you very much.
So,
I really enjoyed the ECG, particularly with the prolonged pair interval with the pacing ECG. And that's something I didn't ever think of, but that's very nice of you to show it.
I can even show you one more ECG. This also comes up a lot when you have Epstein's anomaly. So again, in Epstein's anomaly, what happens is that the atrium is very scarred, but there is really no problem with the AV node. I don't know if you can see my ECG.
Yeah,
we can see it.
Yeah, you can get an Epstein's type pattern, but the PR interval gets longer in those patients again. If Epstein's doesn't involve the AV node, it's only involving the atrium. But because of scarring and slow conduction in the atrium, rheumatic heart disease, severe Sjogren's, rheumatological disease, wherever you have any slow conduction in the atrium, the PR interval is longer because of intra-atrial conduction disease, not in the AV conduction disease. Right.
Dr. Abhishek, if we can share just 2 more ECG and make a quick fire round, anything, whatever you think. So our people will be happy and junior will be learning many things. So if you have quick rapid fire round, maybe 2-3 questions.
I'll just show one ECG and then we can stop.
Yeah, certainly.
Can you see this?
Yeah. Can you make a full screen? Yeah. Yeah. Now, if you can ask the question, then we can definitely go for the polls.
Question is the ECG, is the pacemaker working or not working?
Okay. So we started the poll.
Yes.
We'll wait for 30 seconds.
Yeah. Yeah. question is the pacemaker working or not working? Yes or no? So atrial pacing QRS, atrial pacing QRS, atrial pacing QRS, atrial pacing no QRS,
Okay.
atrial pacing, ventricular pacing, atrial pacing QRS. So what happened here? Is the pacemaker working? This is again part of an AV block, you know, as we see, but is the pacemaker working or not working?
So again, a beautiful mixed bag.
Okay, so good. So some of them say pacemaker is working, some say pacemaker is not working. So, you know, the job of the pacemaker is to pace, but there are certain funny algorithms which are programmed to minimize ventricular pacing. One of them is called as managed ventricular.
Is this patient using AI mode?
Yes. So so some of these modes work in AI mode, and then they change and then they have a mode switch. So what happens here? You have sinus rhythm going on, then you have A paced V sense, A paced V sense. Then as the PR interval prolongs, you can have A pace with no QRS. As soon as the device sees there was no QRS, then the AV, then it gives a backup ventricular pacing, and this thing starts again. So this is managed ventricular pacing. If more than 2 beats get blocked, then the device thinks, well, the AV conduction is not very healthy. So they will start to shorten the AV delay, and then the patient would be paced in the atrium and ventricle again. So this is an example of managed ventricular pacing. So again, dual chamber pacemaker, but sometimes you may not have a V paced beat. That does not mean that the pacemaker is not working. That just means there is some algorithm working in the background. And as you rightly pointed out, this is working in the AI mode. As soon as it saw a beat was blocked, it gave a backup pace here. So not always, you know, you will see a consistent A paced, V paced, A paced, V paced. Good.
That's very nice. Rafiq sir, welcome. Hafiz bhai, are you here?
So again, a great thanks to Dr. Abhishek, and I request Dr. Rafiq if you can say some words, because I think Dr. Abhishek has some clinic going on, so he's a bit busy today. Yeah. So quick question from Dr. Rafiq, and then we'll say thank you to Dr. Abhishek because he has a clinic.
Yeah, hi. Well, I'm sorry I cannot join the whole meeting. I'm in Boston visiting my grandchild, the first grandchild. So thank you. Thanks to have you in the meeting, Abhishek.
Thank you. Congratulations for your grandchild.
Thanks.
Thank you.
So I request Dr. Wadud to put some words, and then we can continue because Dr. Abhishek have to go for this case.
Yeah, Dr. Abhishek, we really enjoyed it. What I enjoy about your lecture is that you make these lectures very practical. What we can actually face in the wards and rounds and in our clinics, and how we can implement this understanding of basic concepts, how atrial conduction abnormality occurs, how AV conduction abnormality occurs, so that we can implement this knowledge in our daily practice. That's the beauty of your lecture. You do not make things very complicated. You seem very easy. Why do you say this? It's become very easy. But before that, it was very difficult for us. It is like that. And thank you again for your beautiful presentation. And we do hope that you will be again gracing our forum again and again. I will be enjoying your deliberations. Thank you, Dr. Abhishek Deshmukh.
I appreciate the opportunity, and let me know when I can come back again. Okay. Thanks.
Thank you so much, Doctor. Thanks. So over to you, Dr. Wadud again.
Hafiz bhai, do you have some ECG to show today? Hafiz bhai, are you with us? I think
he is not here.
Okay.
Maybe he disconnected. So
today, actually, we are a little bit disorganized because of the whole COVID situation and some personal problems. Like Tushar is sick. Today, Adar bhai cannot join. I was in a hurry, everything. And even then, dear audience, we really would like that all of you, if you have an interesting ECG, send it to Professor Atahar Ali or to Dr. Tushar or to myself, and we'll be discussing those ECGs, the clinical scenarios, what to do, what not to do, and how to understand those problems. And that will be better for all of us. Rafiq sir is our mentor. He always tells us that we should be learning in a way that actually becomes useful to us. Otherwise, pure theoretical learning will not last in your mind. And ECG learning actually depends upon seeing lots and lots of ECGs, enjoying it, finding out the intricate problems and the beauties, and discussing them with friends and colleagues, and then finding out the solution, what to do, and giving comfort to the patient. And very often it involves that we should not be engaging in activities trying to do good to the patient, but we will be rather harming them if we do not understand what is going wrong and what should we do properly. That way, we will actually use these programs and the knowledge we gather from here to good use. We can put that to good use. Rafiq sir, do you want to make a comment before we conclude?
Sir left, I suppose. Sir is not here.
Hafiz bhai, are you here? I think he has also left. He's probably gone for it. As an intervention cardiologist, he's very busy.
Rafiq sir
Yeah,
is here.
Rafiq sir, do you want to make a comment, sir? We'll be concluding. Sir, আপনি কিছু বলবেন?
Yeah, now he is live. Yes, sir, you can.
কে ওয়াদুদ?
হ্যাঁ স্যার, আমরা আজকে শেষ করতে যাচ্ছিলাম, আপনি কিছু বলবেন স্যার?
না কিছু না, তো ঠিক আছে।
আজকে লেকচারটা স্যার খুব ভালো লাগছে। It was good. It was actually very practical.
Good.
It was actually very useful to us. I do think so.
Okay, good. All right. আবার নেক্সট উইকে দেখা হবে।
Thank you so much.
We want some good presentation from you. You always do a very interesting situation, very interesting.
I'm not an ECG fellow. If you ask me clinical case, I can present you.
But clinical scenarios, those cases you have presented, all of those are very good.
Yeah,
We
I have.
really enjoyed those.
Yeah, I have one more rare case of pulmonary hypertension presenting with, I think it's a peripheral pulmonary artery stenosis. So I have few interesting cases, but that's not related with ECG.
So again, we'll be meeting in the next week, and till then, goodbye.
Okay, bye.
And good night to everyone.
Good night. Good night.
Thank you.
Eid
Many
Mubarak,
thanks.
sir.
Yeah,
And good night,
many
sir.
thanks to